Good morning to everyone. I hope that my volume is going well this morning. Please let me know if not. I will now put my slides into slideshow mode. So I'm very delighted to be talking to you today about the preterm guidelines. Overall, I wanted to just give you a very brief outline of the scope of our newborn health team recommendations here at WHO in Geneva, and then dive deeply into the development and the implementation of the preterm recommendations. So overall, we focus on conditions that have a high clinical or public health burden, interventions that will have an important impact on this burden, and the guidelines are updated every 3 to 5 years, and we are moving to a computerized living approach in real time, which will be where the guidelines will be triggered as soon as evidence is published. Our guidelines can all be found on our IRIS server, and you can see the link here on the slide. The scope of our guidelines range from essential newborn care, postnatal care, to preterm conditions, to infection conditions, to recommendations for use in hospitals, resuscitation and birth asphyxia, and then there is also an overall compilation that you can see here on the slide. And these are the links to many of our guidelines for your use. So now, importantly, to the preterm guidelines. Again, these have been now published and they are available online, and they were published in 2022, the end of last year. And these are the links to the key documents. The overall scope was to update the previous WHO guidelines for the care of the preterm and low birth weight infant. And you can see the old documents there listed on the slide. The Guideline Development Group went through all of these documents and highlighted important areas that needed updating. And in the slide on the bottom that you can see, the areas in bold were the ones that were prioritized for updating. The ones in italics are the ones that can be found in other existing guideline documents. The process involved the formulation of a Guideline Development Group, intensive systematic review of all of that evidence by the Guideline Development Group, assessment of the quality and the certainty of the body of evidence, and the formulation of recommendations, and also publishing, but also importantly, monitoring and evaluation of the use of the guidelines and also dissemination of the guidelines. The Guideline Development Group involved 25 members from many countries, and I will show you a couple of slides now that I won't spend time on in detail, but they are there for your use, and they describe the Guideline Development Group process in detail. So now I will just jump one by one very quickly through these slides, which are there for your use. Again, this was the specification of the PICOs, the Population Intervention Comparator Group and Outcomes. There was a scoping of overview of reviews. There were 38 systematic reviews commissioned. The Decide Evidence to Decision framework was used. Grading of the certainty and quality of evidence. Formulation of judgments. And just to highlight, importantly, that there are two types of recommendations. There are strong recommendations that these recommendations should be applied to all preterm and low birth weight infants. And there are also conditional recommendations where the recommendation is considered under certain conditions, and those are phrased as may be considered. So we have recommendations that are phrased as is recommended, should receive, and we have recommendations that are phrased as may be considered, which are the conditional ones. And again, these recommendations, as I said, are published online under the links that you can see here on the slide. So now, importantly, to the recommendations themselves. There are 25 recommendations, 11 are new and 14 have been updated. There are 11 strong recommendations that should be implemented for preterm low birth weight babies, and 14 that are conditional on particular contexts or limited evidence. And there's one good practice statement. There are 3 different categories. There are 16 recommendations for preventive and promotive care, 6 for care for complications, and 3 for family involvement and support. And there is one good practice statement. So now to the recommendations themselves. The structure of the recommendations in the guideline document follows this overall structure, which is the domain, the type of recommendation, for example, mother's own milk, the recommendation itself, the status, whether it's been updated or if it's new, and the strength type, if it's a strong recommendation or a conditional or a weaker recommendation. And also in the guideline document, what you will see is that we have the recommendation itself followed by the remarks which explain the recommendation. And there's also an important evidence to decision summary in each of the guideline sections, which outlines all the way through from benefits, harms, certainty, balance, values, acceptability, resources, feasibility, and equity. So now to the recommendations themselves. Dr. Shuchita will focus specifically and in detail on the Kangaroo mother care recommendations. So I won't go through these today, but just to highlight that they are really the pinnacle and the pivotal point around which all of our recommendations fall. But now to the rest of the recommendations. For breastfeeding, we have, as you can see here on the slide, we have 3 key recommendations all around milk feeding of the preterm and low birth weight infant. And as you can see here, we are recommending that mother's own milk is recommended for the feeding of preterm or low birth weight infants. And that includes very preterm or very low birth weight infants. And this was a strong recommendation based on low certainty evidence. However, we know there are situations where mother's own milk is not available. And in that situation, donor human milk may be considered for the feeding of preterm or low birth weight infants, including very preterm babies. Also, there is situations where mother's own milk and donor human milk are not available. And in that situation, nutrient-enriched preterm formula may be considered for very preterm or very low birth weight infants. Also, the important considerations around nutritional supplementation were considered in the guideline development process. And first of all, the guideline development group decided that multi-component fortification of human milk is not routinely recommended for preterm or low birth weight infants, but may be considered for the infants who are less than 32 weeks gestation or very low birth weight, less than 1.5 kilogram infants who are fed mother's own milk or donor human milk. And that was a conditional recommendation because it was based on low to moderate certainty evidence. For micronutrient supplementation itself, for the individual micronutrients, there were 4 recommendations made. First of all, that enteral iron supplementation is recommended for human milk-fed preterm or low birth weight infants, less than 37 weeks gestation or less than 2.8 kilograms, who are not receiving iron from another source. This was a strong recommendation based on moderate certainty evidence. For zinc supplementation, there was a conditional recommendation made because there was low certainty evidence. And this was that enteral zinc supplementation may be considered for human milk-fed preterm or low birth weight infants who are not receiving zinc from another source. Vitamin D supplementation was also recommended as a conditional recommendation because the evidence was low certainty, so that vitamin D supplementation may be considered for human milk-fed preterm or low birth weight infants who are not receiving vitamin D from another source. And for vitamin A, there was also a conditional recommendation made that it may be considered for infants, just the very preterm or very low birth weight infants who are not receiving vitamin A from another source. So overall, 4 micronutrients are recommended for preterm and low birth weight infants. So importantly, so how to feed? What are the recommendations for the mechanism of feeding, or how preterm or low birth weight infants should be fed? So there were 4 recommendations made that you can see on the slide. This was for early initiation of enteral feeding, first of all, that preterm or low birth weight infants should be fed as early as possible from the first day after birth, and that they should be breastfed wherever possible and put to the breast as soon as possible after birth. And infants who are unable to breastfeed should be given express mother's own milk as soon as it becomes available. If mother's own milk is not available, then donor human milk should be given wherever possible. There was also a recommendation, that was a strong recommendation. There was also a recommendation for scheduled feeding, so that it should be considered rather than responsive feeding for preterm infants born before 34 weeks gestation until the infant is discharged. And that was a conditional recommendation. And then, because there's been much evidence published on fast and slow advancement of feeding, the Guideline Development Group made a recommendation for fast advancement of feeding, that feeds can be advanced at increments by up to 30 mils per kilo per day. And that was a conditional recommendation based on moderate certainty evidence. And importantly, for the duration of exclusive breastfeeding, this recommendation was updated, and that preterm or low birth weight infants less than 37 weeks gestation should be exclusively breastfed until 6 months of age. This was a strong recommendation based on very low certainty evidence. So for the other forms of preventative and promotive care, as you can see, these are 2 new recommendations. That there was a recommendation made by the Guideline Development Group for probiotics, that they may be considered for human milk-fed very preterm infants less than 32 weeks gestation. This was a conditional recommendation based on moderate certainty evidence, and the Guideline Development Group specially highlighted that further evidence was needed to decide on strain and formulation and duration of probiotic supplementation in particular. For emollients, there was a conditional recommendation made that the application of topical oil to the body of preterm or low birth weight infants may be considered. And this was also a conditional recommendation based on low certainty evidence. Now, so those were the preventative and promotive care recommendations. Now I'll focus on the recommendations for care for complications, care for preterm or low birth weight infants that have problems. So for CPAP, there was an updated recommendation that CPAP therapy is recommended in preterm infants with clinical signs of respiratory distress syndrome. This was a strong recommendation based on moderate certainty evidence. But also there was a conditional recommendation based on low certainty evidence that CPAP may be considered immediately after birth for very preterm infants, less than 32 weeks gestation, with or without respiratory distress. And the GDG also focused on what type of CPAP pressure source should be used. And they recommended that preterm infants who need CPAP, for those infants, bubble CPAP may be considered rather than pressure sources. And this was a conditional recommendation also. So importantly for the problem of apnea in particular, but for respiratory stimulation overall for preterm infants, there were 3 recommendations made, new recommendations made for the use of methylxanthines. So the GDG recommended that caffeine should be used for the treatment of apnea in preterm infants less than 37 weeks. And for extubation, the GDG recommended that caffeine should be used for the extubation of preterm infants born before 34 weeks gestation. Those were both strong recommendations. The GDG also made a conditional recommendation that caffeine may be considered for the prevention of apnea, so given to all preterm infants born before 34 weeks gestation. This was a conditional recommendation based on low certainty evidence. So finally, the recommendations based for family involvement and support. So as you can see on the slide here, we have 4 recommendations, or 3 recommendations and 1 good practice statement. So the GDG felt strongly that their family involvement in the routine care of preterm or low birth weight infants is recommended. They made a strong recommendation based on low to moderate certainty evidence. For family support, the GDG also made a new recommendation. This was a conditional recommendation that families of preterm or low birth weight infants should be given extra support to care for their infants. And this should start in health facilities from birth and continue during follow-up post-discharge. And that there are key categories of family support, which include education, counselling and discharge preparation from health workers and peer support. There was very little evidence for this recommendation, so the GDG had to make this as a conditional recommendation. It was based on very low certainty evidence. The GDG also recommended that home visits should be provided by trained health workers to support families for care for their preterm or low birth weight infants. This was a strong recommendation made on moderate certainty evidence. However, there was insufficient evidence at this point in time to recommend a particular schedule of care, particular number of home visits that should be provided, or particular timing. This work is ongoing by the WHO HQ office, and we will provide further recommendations about schedules at a later stage. And finally, the important good practice statement that parental leave and entitlements should address the special needs of mothers, fathers, and other primary caregivers of preterm or low birth weight infants. And this was made as a good practice statement. It was a new good practice statement, and the reason for a good practice statement rather than a recommendation was the fact that there was no evidence available from the published literature on parental leaves and entitlements, but the GDG felt strongly that this was a intervention, or this is a recommendation that applied to all families of preterms and low birth weight infants, and that it should be made. I just wanted to highlight here on this slide the new recommendations. I have highlighted these already, but this is a slide for your use, so you can be clear which are the new recommendations and which are not. So I'm conscious of time there. I want to now just go very briefly through some issues around implementation of the preterm recommendations before passing over to my colleague, Dr. Shuchita. So this slide here sort of outlines the process for getting our WHO standards and recommendations into policy and practice, and how they can help build the health system. So overall, you can see we have both the content of care and the scale-up of care. So after we make our standards and recommendations, we focus on updating what we call our derivative tools, which are our clinical practice guidance, our hospital protocols and pocketbooks, handbooks and chart booklets, and digital adaptations of these. We also focus on competencies such as training courses, supportive supervision, and continuous quality improvement. There's a sequence of developing indicators and monitoring, a focus on improving the experience of care of mothers and newborns, which then leads into the building of the health system and the implementation. And we use the health system building blocks very much to enable the scale-up of care, which include financing, infrastructure, commodities, workforce, service delivery, information technology, and governance. Now, on the next slides, there'll be some snapshots of these important areas, which are also there for your use. In the interest of time, I won't go through them in detail, but I would be happy to answer any questions. So you can see here some examples of the content of care, the derivative tools, the IMCI, the Integrated Management of Childhood Illness chart booklet, the Hospital Care for Children, our training courses, and also the Kangaroo Mother Care Practice Guide that Dr. Shuchita will focus on. We also have our tools for scale up, which I'll just show you quickly here on the slide, but won't focus in too much detail. We also have our WHO Essential Medicines list, which is updated with the new commodities that are needed, the new medicines in particular that are needed for the implementation of our recommendations. The UNICEF supply catalogue is also updated with the products that are on the essential medicines list, including the new commodities that are needed for our guidelines. We encourage and we really focus on the updating of regional and country level derivative tools. And some of these are shown here on the slide. And this is a list of additional resources that we hope can be of use to you. And we would be happy to discuss any of these additional resources as well. So I think that's my last slide. I hope I've kept to time and that was clear. I'm sorry I couldn't see the chat as I was presenting, but I'll pass back to our moderator now. Thank you.
So today I will talk about not only a high impact, but also what we can call a transformative intervention in maternal and newborn health. Now, before we go further, I would like to take you back in time. 7 years back in 2015, when this KMC story actually began. Back in 2015, we knew that KMC, when it is started in facilities for preterm or low birth weight babies weighing less than 2,000 grams, it decreases the mortality by 40%. And this was very widely known. And WHO had been recommending KMC for a long time. But if you look at these blue boxes, there were 3 major gaps. The first gap was that despite long-standing recommendations by WHO and a push for implementation by many international organizations, the global KMC coverage was less than 5%. Secondly, evidence only supported KMC in facilities, whether we could start KMC in communities or at home as well. The third major gap was that KMC was to be started only after the newborns, these preterm or low birth weight newborns, became clinically stable. And that meant that the initial 48 to 72 hours where maximum mortality occurs, we were losing the opportunity to save newborn lives during this period. So what did WHO do? WHO undertook a research program, and there were 3 major studies that we did to address these gaps. The first was how to achieve high coverage of KMC at scale. Second was to understand whether KMC can be started in communities or at home. And the third, whether KMC could be started as soon as possible after birth, in fact, immediately after birth, so we could save lives, save the newborns who were dying within these initial 48 to 72 hours before they became clinically stable. The first study, it was an implementation research study conducted in Ethiopia and India across 7 districts involving almost 8 million population. Led by MOH, the study looked at the different ways in which KMC coverage could be improved in the facilities and defined these models recurrently and identified some common areas which could help us improve the population-based coverage of KMC. And they these within the facilities, but there were activities that were done even before the baby reached the KMC implementing facilities. So there were pre-facility activities, activities taken on in the health facilities which were doing KMC, and then after the baby was discharged home. I'll not go into the details, but I'll share all the links to these papers. But the outcome, it showed that using these model, this optimized implementation model, a coverage of almost 53% to 72% of KMC, of population-based KMC was achieved across these 7 districts. And this coverage not only this coverage included 8 hours of skin-to-skin contact per day, plus exclusive breastfeeding. So it was high quality KMC coverage, not just any KMC. So you can see the vast increase it achieved from a baseline coverage of 5%. The second study was a randomized controlled trial which evaluated the effectiveness of KMC started in the community against KMC which was routine. The study involved 8,400 stable 1.5 kg and more than 1.5 kg because the babies who were less than this have to be referred to the facility. So you can't keep these babies in the community and do KMC. You have to refer these babies to the facilities. So these babies were identified and KMC was started within 72 hours at home. Now, these babies could have been the babies who were born at home, or these could have been babies who were discharged from the hospital early, that is within 72 hours after birth, and sent home. So these babies were given KMC at their home, and this was compared to the routine care, which in the Indian context, it comprised almost 7 to 8 home-based visits by community health workers. But the difference was that these community health workers, they were not specifically trained in KMC, and they might not have provided as good a support as was provided to the intervention group. So this study showed that almost 30% newborns, the mortality, there was 30% lower neonatal mortality in the intervention group compared to the comparison group. The third study was on evaluating the effectiveness of immediate KMC. This was a multi-center randomized trials undertaken in 5 countries, Ghana, India, Malawi, Nigeria, and Tanzania, and enrolled more than 3,000 mothers and babies with a birth weight between 1 to less than 1.8 kg. So this is a group which would definitely require health facility care inside the newborn care unit in most settings. And in these babies, the KMC was started as soon as possible after birth, irrespective of whether the babies were clinically stable or not. And this was compared to KMC started only when the newborns became clinically stable. % lower mortality, neonatal mortality in the intervention group. So based on this key evidence, if you extrapolate it to how it would translate to saving newborn lives, if you calculate the impact of the traditional or conventional KMC, as I might call it, looking at the 5% coverage we had in 2015, with a 40% reduction among babies who are less than 2,000 grams, we could only prevent 10,000 deaths per year. But if you add to it the impact research, which could help you coverage to 60%. And that is a conservative estimate, given that there was a variation in the coverage achieved across different districts. If you look at 60% coverage, it drastically improved the number of lives that we could save to 150,000. If you add to that the impact of community-initiated KMC, then you increase the coverage, because now you are starting KMC not just in health facilities, but also at home. So improve the coverage from 60 to 80%, but going to the lower reduction of 30%, you end up saving 250,000 lives. And again, if you add to it the impact of immediate KMC, which would save many more lives in the initial 48 to 72 hours of birth, then you reach up to 400,000 deaths prevented per year. So you can see the high potential of impact on newborn survival that can be achieved by implementing these research findings in programmatic settings. But we need a consensus on how we can do it to maximize this impact. Now, considering all this new evidence that came up in the last 5 to 7 years, WHO updated its KMC recommendations in the guidelines last year in November 2022. Now, if you see, the first recommendation is that KMC is recommended as routine care for all preterm or low birth weight infants. So if you compare from the earlier recommendation, earlier we said infants less than 2,000 grams. But now we are saying it should be given to all preterm or low birth weight infants. Then KMC can be initiated in the healthcare facility or at home. So for babies who are born at home, discharged early after facility birth, who are otherwise stable, so they don't need care in a newborn care unit, those babies can be given KMC at home. And third and other important difference is that it should be given for 8 to 24 hours per day for as many hours as possible. So earlier we said, you give it for as many hours as possible, but we did not put a timeline. But now we are saying it should be at least 8 hours per day to as long as 24 hours per day as possible. And this is a strong recommendation which is based on high certainty evidence. The second recommendation, which is new, is that KMC for preterm or low birth weight infants should be started as soon as possible after birth. Earlier we said you start after the newborns become stable. But now we are saying you start it as soon as possible after birth, irrespective of the clinical stability, unless the newborn is critically sick. And by critically sick, I mean the definition could vary by context, but usually we mean babies who are on inotropes, or babies who require mechanical ventilation, etc. So that is a critical level of sickness. If the baby is not critically sick, just requires, say, example, CPAP for respiratory support, you can start KMC in those babies as soon as possible after birth. The other recommendations, which Karen has already referred to, are around family involvement and support. But why I have flashed them here again is because these are very important to implement in order to do KMC. Okay, so if we want to have KMC, we also need to have and consider implementing some of these recommendations, which include family involvement in the routine care of preterm or low birth weight infants. Now, usually what happens is that most of the health facilities, they have a fixed visiting hours during which the mother, the father, other family members can come and just visit and see the baby and go back. But what we are asking is that they should be involved in the routine care of babies as well. The second, not just we involve them, we should also provide them extra support to care for these babies, because these babies, they're fragile. They need good care, and parents are not prepared. Parents and families, they are not prepared to take that care. So we want them to be involved in the routine care, but we also need to provide them this extra support in the form of education, counseling, discharge planning, peer support, so they can take good care of these babies. Then the home visits. Once these babies are discharged, then trained health workers should visit to provide support to the babies at home. And lastly, but not the least, the parental leave and entitlements. Now, we know that the preterm and low birth weight babies, they need more prolonged, more intensive support. They have these special needs, and extra needs compared to the normal babies. So parental leave and entitlements should address these special needs, and perhaps they should be given additional leave from work or additional financial support to take care of these babies. Of implementing these recommendations. We have talked about the recommendation, but now when we think of implementing these recommendations, what are the key principles we need to keep in mind? And I'll just highlight 4 or 5 key principles, because now you have to think of how it will be operationalized in practice. Now, the first thing you need to remember is that KMC is prolonged skin-to-skin contact, preferably for 24 hours daily and for a minimum of 8 hours, with support for exclusive breastfeeding or breast milk feeding. Now, this is different from the skin-to-skin contact that we provide to all newborns in the first hour after birth. Okay, so that is also a standing WHO recommendation, but that is only from the perspective of temperature maintenance, initiation of breastfeeding. But KMC is more than that. KMC is prolonged skin-to-skin contact. Okay. Then KMC also features timely transition to the lower levels of care. So once the baby is out of the newborn care unit, then the KMC should continue in the, say, for example, postnatal ward, or even after discharge into the community with close monitoring. The second important principle is that mother and her infant must remain together at all times. Now, the current practice in most settings, what happens is that as soon as it is decided by the pediatrician or the neonatologist that the newborn requires care in the newborn care unit, so baby is born, they examine the newborn, they say, oh, no, baby is sick. You need to transfer the baby to newborn care unit. What happens? Mother is aside now, the healthcare providers, they take on the care of the baby, and she's completely disempowered. She's only allowed to visit the newborn, just to see the baby through the glass wall, or sometimes, she's allowed to visit to give the breast milk, etc. But the care shifts from the mother to the healthcare provider. Now, if we practice KMC and immediate KMC, we restructure, we reposition this power within the health systems, and mothers, they actually get to care for their infant in a more holistic way. So she becomes central to the care of her infant, and she feels more empowered, and it humanizes both the mother and the newborn care. Now, the third most important principle is that not just the mothers, we don't just involve the mothers in this care, but we also involve the fathers, partners, and families, because mothers, they themselves are in a very, they might have had a difficult delivery, they might be recovering from cesarean section, etc. So they also need support in caring for the baby. So the fathers, parents, and family should also be supported to provide the required support to the mothers while she's providing KMC in the facility or at home after discharge. The third important principle is that KMC should not be done alone. So we are not saying that, okay, this is the single magic bullet that you take and run away with, and you do KMC and everything would be sorted. No. We are saying that done as part of the comprehensive quality small and or sick newborn care. So for any unit to do good KMC, you also need to have some minimum standards of care for small and sick newborns. So you need to have all the key essential newborn care interventions in place and add KMC to it. So it's not something that has to be done in isolation, but alongside quality small and sick newborn care. And we should all remember at this stage that this is not a low resource strategy. So you're not saying that you do KMC because you don't have incubators, you don't have warmers, you don't have enough money to purchase equipment. No, it is not a low resource strategy. In fact, it is superior to the current high-tech strategy, which involves this high-tech support from incubator, warmers, etc. So that's something we need to remember when we are thinking of KMC and immediate KMC. And last but not the least, we should implement KMC at all levels of care, primary, secondary, and tertiary, including at home, and all system building blocks, right from leadership and governance, looking at how the care of the small and sick newborns will be financed, etc. What are the infrastructure changes that might be required in healthcare facilities? We need to look at all these health system building blocks in order to operationalize KMC and quality, along with quality small and sick newborn care. Now, coming to the specifics. So these were just the broad principles that are highlighted, but coming to the specifics. Now, we have three major changes, as I told you, in the current recommendation. One is it should be done for all preterm or low birth weight infants. Now, that is a very large group. Now, between 2000 to 2500 grams, that is a large group of preterm or low birth weight babies. Now, if we have to provide KMC, make sure that KMC can be provided in postnatal wards at all levels of care. So it could be postnatal wards, it could be kangaroo mother care wards, it could be anywhere. But we need to now think about this big chunk of babies who need to be provided KMC and how we will do it. The health workers will definitely need to be trained and supervised because they might not be aware of it and they might not have practiced it before. Thirdly, the facility policies need to be strengthened to always keep the mother and newborn together and ensure that adequate facilities for the mother are present. So you cannot expect the mother to stay in the hospital and provide 8 hours of, at least 8 to 24 hours of skin-to-skin contact if she does not have access to toilet, if she cannot bathe herself, if she does not have food, drinking water. So those are the basic facilities we need to provide to make sure that, mother is able to provide the KMC for as long as we would want her to. And last but not the least is again monitoring the KMC coverage and quality. We all know that, unless you measure, you'd never know where you are and how well you are doing. So it's important that we have some indicator to measure KMC in the health facilities and in the health systems. Coming to the new recommendation of immediate KMC. Now, immediate KMC, that is, you are starting KMC immediately after birth. What do you need for that? See, even before the mother delivers, in most of the facilities, and from my understanding of maternal newborn care, a mother cannot, right after giving birth, if she has given normal vaginal delivery or she has had cesarean section, perhaps the obstetrician would want her to be under observation for say 1 or 2 hours. And even the mother, she might be sick or she might not be able to provide KMC. So you need to identify some other family member like mother's mother or the baby's father or other family members provide KMC immediately after birth. We call these people as surrogates. Okay, though people other than the mother who can give KMC. So we need to do that. We need to allow these people, whosoever the mother has identified as surrogate, to accompany her in the labor room so they can initiate immediate KMC, and then all the provisions for respectful maternal care that I've spoken about. If the baby is sick and needs care in the newborn care unit, and we want prolonged KMC for 8 to 24 hours, we cannot do it by having the mother as a visitor in the unit, okay? We will need to keep the mother inside the newborn care unit with the newborn, even when the baby is sick. Now, this is a major change. This is not a small thing that we are asking for, that you have a bed for the mother beside the radiant warmer in the newborn care unit. And the way that this was done in the immediate KMC study, patients that are possible. Some people, they created an entirely different unit where the mothers and babies could be together. In some other facilities, like in some countries in Africa, they just dedicated half of the portion of the newborn care unit where the babies, there were the babies' beds or warmers, and then there were maternal beds besides that. So several adaptations are possible depending on your context. The most important principle is to keep the mothers and babies together, even when the babies, they require SNCU admission. And then if the mother is with the baby inside the newborn care unit, she also has postnatal care needs. So the maternal care providers need to take care of the mother alongside the baby. So while you'll have rounds from the newborn care people, they will come and see the newborn. We also need to have the maternal care providers coming into these units and examining the mother and providing her the care she needs. And adequate support will be required for both the mothers and the families. Again, family involvement, it will require favorable facility policies. We need to be sensitized as health providers that, how we can make them comfortable, how we can, involve them and, train them. And we also need to be good with the communication skills so that, we can give the right messages and, make them feel part of the newborn's care. Now, this is the kind of unit you'll see, these are some of the pictures where you can see that the baby is on CPAP and yet the mother is providing KMC and father is there and the healthcare provider is there to support. So all these babies you'll see, they are very sick, they are on CPAP and yet they are being provided KMC. So we will need a change in the layout of the SNCU, NICU infrastructure to enable the mother or the surrogate and the family to be with their preterm or low birth weight infant, and also allow the fathers and other family members in the postnatal or the KMC ward so they can support the mother to give as long a KMC as possible. Now, the one thing that you might notice here is that these are they appear to be very big rooms, but you don't need such a big space. Maximum, I think, around 40 square meters to accommodate the mother's bed and the baby's bed. Now, very quickly wrapping up now, these are the high-level programmatic actions that will be required in order to, do these things within a country or a district. So these are like moving away from obstetric and neonatal services. So currently we have the maternal unit, obstetric unit separate, neonatal services separate. But now we need to organize them so as to provide combined maternal newborn care. And, you'll have to have a policy where mothers and newborns, how they can be cared for together in one location and what the different providers' roles would be to provide that care. We need the commitment of the political and program leadership to integrate KMC, to see KMC as an essential core component of small and sick newborn care. We need KMC supportive policies with a national KMC implementation plan, a monitoring and evaluation framework at both the facility level and in the health management information systems. We need some indicator which can tell us what is the coverage and quality of KMC. But most importantly, it is the barrier is us. Barrier is the healthcare providers, because we think mother is dirty, we cannot allow her inside. How can she stay with the newborn and care for them when they are sick, So we need to change our mindset as healthcare providers and see how we can implement KMC, because it is so much more effective than what we could do alone. Then also creating a functional network of care, improved referral transport so that more babies can be transported from lower level facilities to the IKMC implementing facilities, and then adequate and sustainable financing. I will just leave you with this. So because KMC, it was such an important intervention, it had such a it has a potential to save so many newborn lives, but nothing was moving on the ground. Okay, so the coverage was very low. What the WHO has this technical advisory group, which directly reports to the Director General at WHO. They asked WHO to convene a multi-stakeholder group at the global level involving all these partners that you see listed here. And all these partners, they came together and they developed two guidance documents. One was the global position paper which just essentially summarizes all that I have stated today, and also an implementation strategy which could guide how these recommendations could be operationalized in a country context. And Karen referred to the KMC practice guide. This practice guide WHO published first in 2003. It is basically for the healthcare professionals on ground who are practicing KMC and they want to know how to do it. So we are currently updating this guide and it should be available by the end of this year or early next year. And you will have all the resources with link to all the videos, etc. on practicing KMC. And alongside, we're also undertaking an implementation research to understand how to operationalize immediate KMC, because that is not an easy thing to do. And it is currently not part of policy and program in many countries, in fact, in most countries. And with that, I will summarize my presentation by completing this story. So we identified the research gaps in 2015, decided to undertake this multi-country research and came up with the guidelines in 2022. Then we developed the strategy on how it could be implemented on ground. And now we're also working on, WHO has also developed an indicator to monitor the routine coverage of KMC. So we've come a full circle. We have all that we need now to implement KMC as part of policy and programs in the countries. It is a transformative innovation in newborn care, and we need to implement it to save more and more newborn lives, as many newborn lives as we can, because we owe it to them as healthcare professionals, as public health professionals, and in our role as maternal newborn care providers in whatever capacity we are working in. These are all the links to the key materials, and you can use them freely. They are all available freely online, and you can use them as much as you can to further this cause. With that, I end my presentation and over to you, Sithu. I hope I didn't overshoot my time.